One of the problems with upper GI cancer is that some of the early symptoms you get may actually be no different from the symptoms you get with a bit of dyspepsia, and therefore it is about looking at patients' risk factors. Do they smoke, their lifestyle, obesity, their age. We know that clearly patients have onset of dyspepsia over the age of 55 should be referred straight to test for endoscopy. And is therefore being, I think, aware of patients' response to treatment or lack of response, which should stimulate the general practitioner to refer for investigation.
One of the main difficulties with liver and pancreatic cancer is often the early symptoms can be very difficult to detect, and they're often very nebulous symptoms. They may be very mild, just a little bit of abdominal discomfort, change in bowel habit, maybe a little bit of weight loss, change of indigestion type symptoms. If patients are lucky, then a small tumour will pinch off a bile duct, and that will bring the patient to doctor's attention more quickly. I say lucky, obviously any tumour is not lucky, but that means the patient may well be operable. So it's really a question of looking at the pattern of the symptoms. If someone hasn't had symptoms before, and particularly later on in life they develop symptoms which are pretty consistent, and particularly if they're gradually getting worse and nothing really seems to make him better, then those are the ones which one would definitely be more concerned about, even if they haven't caused the classic 2-week wait symptoms.
The most pressing thing that we have to work out is how to try and differentiate those patients that have non-organic disease, so simple dyspepsia or a bit of gastritis, from those that have cancer. And that is one of the biggest challenges that I think faces us in primary care.
And again, very difficult because often they don't differ from the symptoms of other abdominal conditions, particularly in the early stages. Obviously later on the patient may have more significant weight loss. With pancreatic cancer, the pain will be radiating through to the back. The patient may go jaundice with the more advanced tumours, but in terms of how they differ, often they don't, and it really is again emphasising the question of having an open mind that the patient may have the condition. I think that's probably the most important thing. And the second is then to very much delve into the pattern of symptoms to try and pick up those symptoms which are really quite continuous rather than very intermittent as being more likely to be causing cancer. In terms of investigations, it's very important to carry out a formal abdominal examination of the patient. You may well pick up a large liver or jaundice. Blood tests are clearly indicated, and a routine set of blood tests, full blood count, ESR, U's and D's, LFTs, calcium, glucose, maybe an amylase. They can be very helpful in picking up someone who has got an early tumour. Mild abnormal liver function tests in combination with the symptoms can help to direct towards the next set of tests, which would be scanning, really, cross-sectional imaging or ultrasound. Ultrasound is a very good, low-risk, easy available test which should be used as the primary examination for hepatobiliary cancers. But CT scanning is becoming fast and furious the most useful test, or really always has been the most useful test. One has to be a bit careful about the radiation dose, particularly in young people, but in people in which there's a reasonable suspicion of cancer, then progressing to a CT scan is appropriate, and obviously GPs will become have more accessibility to CT scanning as we move forward.
If general practitioners are worried about a patient having an upper GI cancer, there are, I think, very clear pathways along the 2-week wait cancer pathway, and often these patients will be triaged straight to endoscopy for an urgent gastroscopy within 2 weeks. And I think that is actually the most important thing, to follow the pathway.
I think really the patient should be referred early. If the patient has 2-week wait symptoms, then clearly the 2-week pathway is appropriate. If the patient has more advanced disease, then a direct contact with the specialist for an urgent consultation would be appropriate. And I think increasingly we should be opening our doors much more to GPs being able to ring us up directly. I think that one of the ways we should be changing our services is to not have the only access, fewer the kind of standard routes of referral, 2-week wait or standard referral, but there must be others, more use of the choose and book advice and guidance, or just direct contact to us. We must make ourselves more available for advice. But really the most important thing is a referral at an early stage. I don't think we would worry about seeing a patient with minor symptoms early.
Different hospitals have different support pathways if general practitioners are concerned. Certainly at the Whittington, my hospital, we have both a email address if GPs have queries about whether or not to refer, what investigations, which we can respond by email. There is a GI hotline as well, a telephone line, and we can dispense it, and give advice over the phone.
Again, similar answer really. I think the consultants should be the people who are there to support the GPs.
The early diagnosis of cancer is really very important, and much more so in upper GI cancer, in esophageal cancer and gastric cancer, because whilst it may be only the 10th or 13th most common cancer in the UK, actually it's got such a high mortality because patients often present late. And we know therefore from the Japanese experience, where they offer a screening program, that if we can detect cancer at an early stage, we can try and offer curative solutions, curative surgery, and therefore improve and reduce our mortality rates from cancer of the esophagus or stomach.
HPV cancers are unfortunately one of the highest mortality cancers, particularly pancreatic cancer. We may well be able to offer the patient curative treatment. At the moment, that's a very small proportion of our patients. We are very much hoping that as we diagnose patients earlier, we'll see mortality drop. London has a very high instance of patients who have risk factors for hepatocellular carcinoma in particular, so viral hepatitis, hepatitis B and C, for which HCC, they are risk factors for HCC, and so this is a particular issue for London, but we are, like other areas of the country, seeing increasing rates of pancreatic cancer as well.
London, I think, is a huge diverse population. I think there have been issues about the early pickup of disease, especially in London, for example in colorectal cancer. And I think therefore we've got to be much more pragmatic about increasing public awareness, especially in London, about patient symptoms and therefore early referral.